Hello, welcome to the fourth lecture on the urinary system. Today's lecture is about tubular secretion. Remember that this is step 3. So step 1 was filtration of the blood, and so we had impurities in the blood being filtered out into the glomerular capsule and then into the tubular system. Step 2 is reabsorption, in which molecules in water from the tubules are reabsorbed back into the blood. And then this is step 3, tubular secretion. And so basically this is going to occur in the proximal convoluted tubule. And this is the movement of substances from the peritubular capillaries through the tubule cells into the filtrate. So some of these molecules are potassium, protons, ammonia, creatinine, organic acids, bases, and then anything synthesized in the tubule cells. And for example, this is going to be bicarbonate. So this is step 3, and we see here that step 1 takes place in the glomerulus, and that, so let's look here. This is step 1, takes place in the glomerulus. Step 2 then is going to be the movement of solutes in water, etc., out into the interstitial space and into the peritubular capillaries. And so this is step 3. This is step 3, where we have substances being secreted from the blood into the tube. And this is mainly going to occur in the proximal convoluted tubule. Why is this important? Well, we want to get rid of drugs, metabolites. We want to get rid of any substance that may have been passively reabsorbed, such as urea and uric acid. And then we want to get rid of excess potassium. Usually in the American culture, we don't see too much excess potassium. We see a lot of excess sodium. And then fourth, we're going to see that by getting rid of protons or bicarbonate, then we can control the blood pH. And remember, blood pH needs to be 7.35 to 7.45. So here's a summary. Let's look at this of reabsorption and secretion. So in the cortex of the kidneys, where we have the proximal convoluted tubule. So here's the proximal convoluted tubule. 65% of the filtrate is reabsorbed. And this is going to include water, sodium, bicarbonates, other ions, glucose, amino acids, and nutrients. In the distal convoluted tubule, then we're going to see there's regulated reabsorption of sodium and calcium. What do we see moving in the medulla? What do we see moving out of the descending limb of the descending limb of the nephron loop is water. And then in the ascending limb of the nephron loop, we see sodium, potassium chloride are being reabsorbed. And from the collecting duct right here, we see that there's regulated reabsorption of water and sodium and urea from the collecting duct back into the interstitial spaces. So what is taking place in secretion? What we see is the movement of solutes, all right, This could be protons, ammonia, some drugs are going to move out of the interstitial space and into the proximal convoluted tubule. There is also some regulated secretion from the blood and the interstitial tissues back into the distal convoluted tubule, and this is mainly going to be regulated by aldosterone. Notice that urea, okay, gets moved, and then once again potassium is going to get moved from the interstitial spaces in the blood back into the convoluted, the collecting duct to be peed out. So what do we see here at the bottom? Is that reabsorption or secretion to maintain blood pH. We're going to talk about in chapter 26, but it involves protons, bicarbonate, and ammonia. All right, so when we look here, what we see is basically a function of the kidneys is to make any adjustment that's needed to maintain body fluid osmotic concentration. This is going to be measured in osmolality. Osmolality. This is physiological talk for the number of solute particles in 1 kilogram. Notice this is by weight of water. So 1 osmole is 1 mole of particle, molecule per kilogram of water. Since our fluids are very small, think about inside the cell, it is expressed in milliosmoles. Milliosmoles. And so what we see is that in the body, we want to have around 300 milliosmoles as the concentration. So it depends on how much fluid you've had to drink, whether or not you get a small amount of urine or a large amount of urine. If you have small concentrated urine, then your body is probably dehydrated. Or if you have large amount of urine and it's very dilute, then you're probably overhydrated. Very rarely do we see overhydration. How does this happen? How does the body know whether to concentrate urine or dilute it? And this is the counter current mechanism. The counter current mechanism. This is very important. So you need to study these slides and understand what's taking place. Basically, the fluid in the ascending and descending nephron loops flow past one another. And so they're going in 2 different directions, and this sets up a gradient. So there are 2 types of countercurrent mechanism. You need to know both. There is the multiplier and the exchanger. The multiplier is the filtrate flow in the ascending, descending limbs of the loops of the juxtamedullary nephrons. Please pay attention to that. Juxtamedullary nephrons. This is the countercurrent multiplier. The countercurrent multiplier is in the juxtamedullary nephron loop. Now the countercurrent exchanger, all right, is the blood flow in the ascending and descending loops of the vasa recta. The vasa recta. So countercurrent multiplier, we are looking at filtrate in nephron loops. Whereas in the countercurrent exchanger, we're looking at blood flow in the vasa recta. Blood flow in the vasa recta. So let's look at this. These work together, and they establish what's called the medullary osmotic gradient. The medullary osmotic gradient. And so this goes from the renal cortex through the medulla, and this is in the interstitial fluid of the kidneys. And this gradient runs about 300 milliosmoles up toward the cortex, and then 1200 milliosmoles at the bottom of the medulla. The countercurrent multiplier creates the gradient, while the exchanger preserves the gradient, and the collecting ducts use the gradient to decide, do we need very concentrated urine or do we need dilute urine? Okay, take a minute here and check your notes. So let's look at this picture. Look at the kidney, and what you see is that in the cortex, you have the nephron, collecting duct, you see the arrangement of the structures, you see the proximal convoluted tubule, the descending loop of the nephron, the descending arm of the nephron loop, the ascending arm of the nephron loop. And what we note here is that in the cortex, the osmolality is at 300 milliosmoles, which is isotonic, right? Isotonic to the blood. Whereas as the loops descend into the medulla, we see that milliosmoles are going to move from isotonic, okay, at 300 up to 1200 milliosmoles. And notice that this is going to be at where the papilla of the renal pyramid is. So here's the big picture. Notice over here we have 300, all right? Down here at the bottom, 1200. Keep that in mind. So what we see is that the nephron loops of the juxtamedullary nephrons create the gradient. So they act as the counter-current multipliers. Whereas the vasa recta, the blood capillaries, preserve that gradient, acting as countercurrent exchangers. So you've got multipliers and you've got exchangers. And then the collecting ducts are going to use the gradient to adjust the osmolality of the urine. Take time and go over this picture. Take time and look at the picture. Let's look at the multiplier in more detail. The multiplier involves the nephron loop. We know this. We know that the filtrate flows in opposite direction with the descending and ascending arms. But we need to understand that the permeabilities between the descending arm and the ascending arm are very different, and that active transport of solutes happens in the ascending arm or ascending limb. So we have use of energy getting solutes out, okay, out of the ascending limb. So the ascending limb is impermeable to water. Impermeable to water. What does that mean? That's right, water can't get out, but it is selectively permeable to solutes, to molecules, especially sodium and chloride. Especially sodium and chloride. So we know that water always follows sodium, but if the ascending limb cannot, right, it's not permeable to water, and so sodium and chloride are reabsorbed into the thick segment, but water can't follow it. A difference in permeability, we're looking at the descending limb, and with the descending limb, we see that it is freely permeable to water, but it is impermeable to solutes. So water can pass out of the filtrate into the hyperosmotic medullary tissue. Note the term hyperosmotic. All right. What does this mean? This means water can move into the medullary tissue from the descending limb, okay, but it's going to keep the solutes inside the tube. The ascending limb cannot, right, it's impermeable to water, but sodium and chloride can be reabsorbed in the thick segment. Okay, so what does this mean? This means the filtrate osmolality is going to increase. It is no longer going to be isotonic to blood. So the more sodium chloride the ascending limb transports out into the kidney fluid, remember, out into the kidney, out, out, out. Let's try again. Out. The more water diffuses out of the descending limb. Okay? If the ascending limb is actively transporting sodium chloride into the kidney interstitial fluid, then more water is going to diffuse out of the descending limb. The more water that diffuses out of the descending limb, okay, saltier or more concentrated the filtrate becomes. The ascending limb can use a salty filtrate to raise the osmolality of the medulla interstitial fluid. So this is a cycle. So the constant difference between the two limbs of the nephron loop, okay, and between the ascending limb and the interstitial fluid is around 200 milliosmoles. And this difference gets multiplied along the length of the loop so that you go from 300 milliosmoles to 1200 milliosmoles. Got it? That's a difference of 900 milliosmoles. Take time and study this picture. This is giving you what's taking place in this osmotic gradient. Osmotic gradient. So I'm going to let you read through this. I've already been through it, but I want you to read it and to study it and understand what's taking place. What about the exchanger? Well, the exchanger, remember, is going to use the capillaries, the vasa recta. And the vasa recta is highly permeable to water and solutes. So flow of the blood in the vasa recta is a countercurrent so that blood can exchange sodium chloride and water with the surrounding interstitial fluid. So the blood inside the vasa recta is going to remain isomotic with the surrounding interstitial fluid. This means reabsorption in water and solutes can take place without the osmotic gradient being interrupted. So the exchanger preserves the medullary gradient by preventing rapid removal of salt from the interstitial space, okay, and removing reabsorbed water. So water in the ascending vasa recta comes from the descending vasa recta, or it's reabsorbed from the nephron loop and collecting duct. What does all that mean? It means that the volume of blood at the end of the vasa recta is greater than it was at the beginning. So when you look at this, remember that the vasa recta is highly permeable to water and solutes. There is a counter current exchange. Okay, so the blood within the vasa recta remains nearly isomotic to the surrounding fluid. Notice the numbers inside. Okay, notice the numbers. Go from 300, 600, 1200, and it's going to be the same as the interstitial fluid, so that you have a countercurrent flow. A countercurrent flow. This means that the blood can reabsorb water and solutes without messing up the osmotic gradient. It's going to take a little while. I would encourage you to watch the crash course videos on the urinary system. They do an excellent job talking about the countercurrent exchange. Once this gradient is established, it can be used to form concentrated urine or dilute. Without it, then urine would always stay isotonic to blood, and we'd lose all of our water. I said overhydration usually doesn't occur. People tend to be dehydrated, but basically overhydration is going to produce a large amount of dilute urine. ADH and aldosterone are going to play a part in this. Dehydration, you get a small amount of concentrated urine, and in severe dehydration, then your body will do its best to reabsorb as much water as possible, and this is going to affect the glomerular filtration rate. What about urea? Urea is going to help form this gradient. It enters the filtrate in the ascending limb of the nephron loop, facilitated diffusion, so no use of energy. And then in the cortical collecting ducts, will reabsorb water, and that leaves the urea behind. So basically you have a highly concentrated urea going into the medullary region, and it will leave the collecting duct and enter the interstitial fluid of the medulla. It'll then move back into the ascending limb and go round and round and round and round. And so this helps establish that 1200 milliosmol in the medulla. What are some of the ways we can treat urinary output? We have diuretics. So think about a diuretic as something that makes you go pee. So ADH is anti-diuretic hormone, and that helps your body conserve water. But if you take an ADH inhibitor, such as you drink a lot of iced tea or you drink a lot of alcohol, you're going to have to pee. And so those are inhibit ADH. Sodium reabsorption inhibitors, okay, which also means that water is not going to be reabsorbed. This would be caffeine or drugs for hypertension or edema. So anything that interferes with sodium reabsorption also interferes with water reabsorption. And that's what iced tea and coffee do to us, caffeine. And then we have loop diuretics. This inhibits the medullary gradient formation. And you have to be real careful about that. And then osmotic diuretics. So substances are not reabsorbed, so water remains in the urine. An example of this would be diabetes, whereas high glucose concentration pulls water from the body. In other words, where there's glucose in the urine, which there should not be. It should be reabsorbed. But if there's too much glucose in the blood, it'll wind up in the urine. And basically what's happening is that glucose, as it's in the filtrate, pulls water from the medullary tissues and eventually into the urine. It's made into urine. How do we clinically evaluate? Well, we can do blood test and look for nitrogenous waste. Usually the easiest thing to do is to have your patient pee in a cup and use a dipstick. And if we were at school, you would have peed in a cup this past Monday on the 30th of March and done a dipstick and a microscopic analysis of your own urine. Yep. It's lots of fun. That's what I did every morning in high school. After I drew blood from patients, I went back to the lab and I did all the urine analysis. It's so much fun. If the kidneys can't filter the blood, it's called renal failure. And this means we have a glomerular filtration rate of less than 15 milliliters per minute. What happens is that we have uremia. Remember, emia is in the blood, so we have urea or nitrogenous wastes that wind up in the blood. This is a very toxic molecule and it will damage the liver, heart, the brain, and a lot of times, quite bluntly, people don't recover. The way to treat this is hemodialysis, which is basically a port is put into your arm or into your chest to an artery. Yes, it's a connection between an artery and a vein. And the arterial blood gets pumped out into a machine that acts like an artificial kidney, and then it gets pumped back into your blood system, your cardiovascular system, and this may take several hours because it has to pass through the artificial kidney many times to clean up your blood. So this is dialysis. You can also do kidney transplants. This is usually a last resort. Sometimes it works and sometimes it doesn't.